Regular Helon is now injected above the anterior capsule leaf in order to bring down and attach it to the posterior capsule. Then the central posterior capsule is flattened, thus creating a common planar capsule diaphragm. Then a 30-gauge hypodermic needle, bent bevel up, is tangentially approached to the central capsule, aiming at lifting up a fold and then perforating it. Other than usually taught, OVD is not yet injected through the slit created. Instead, the edge of the capsule slit is grasped with blunt capsule forceps, and the capsulorhexis is initiated. Only now is OVD injected in order to separate the anterior hyaloid from the posterior capsule. This avoids injection of OVD into the vitreous body should a firmly attached hyaloid have been inadvertently punctured together with the posterior capsule. The posterior capsule edge is then regrasped by forceps, and the capsulorhexis is completed with 2 or 3 additional passes. Using a blunt cannula, Helon is injected beneath the posterior capsulorhexis edge in order to circumferentially visco-dissect the anterior hyaloid from the peripheral posterior capsule. The advancing dissection line can thereby be easily visualized. Now the nasal capsular fornix is reopened and prepared to accommodate the leading IOL loop. The injector tip is inserted through the tunnel with a slip-oriented sideward to exclude tissue trauma, to then be rotated clockwise to allow the leading loop to exit horizontally and settle in the reopened nasal fornix. The exposed piston gently pushes on the temporal optic aspect in order to entrap it beneath the posterior rhexis edge, which prevents the edges of the unrolling IOL optic from touching the subincisional endothelium. In this live surgery case, the inferior optic edge happens to slip under the posterior capsulorhexis, which is easily corrected for by simply lifting it up with a spatula. Using a Y spatula to gear the trailing loop, while a blunt spatula is positioned on the anterior optic surface, the trailing loop is also inserted into the capsular fornix while slightly rotating the IOL. After recentering the implant, the optic is entrapped in the posterior capsulorhexis by gently pushing on the optic periphery 90 degrees away from the IOL axis. After draining some of the OVD by depressing the tunnel bottom, and after hydrating the paracentesis openings, a coaxial I&A probe is inserted and the residual Helon aspirated with the aspiration port pointing upwards and to the sides. Finally, the I&A probe is quickly retracted to allow the self-sealing corneal lip to shut down, thus excluding anterior chamber shallowing. The optic now centers within the posterior rhexis buttonhole, and the posterior capsule is seen to overlap the optic periphery while its edges undercross the haptic optic junctions.